Bismillah ar-Rahman ar-Rahim. I'm honored to be here with my professor and colleague. We will discuss ICD interpretation. During ICD interpretation, I want to assess clinical assessment of the patient, the device function and integrity, the events stored, whether with appropriate therapy or not, and redo device programming if needed. This is the first screen we will get during interrogation. The quick summary or the fast summary. We can get the lead integrity, impedance. We can get the lead impedance, basing threshold and sensing, battery longevity, percentage of basing episodes recording, and whether there was oversensing or not. Then the first thing I will do is checking the lead integrity and battery integrity. Lead impedance, which should be between 200 and 1000 for the sensing lead, and for the high voltage lead between 30 and 120 ohm. The sensing of the B wave and R wave should be accepted at least for the atrial sensing 1 millivolt and for ventricular sensing 5 millivolts. And basing threshold should be checked. The device will do periodic check of the impedance, and we will get the impedance trend. Here, the impedance at implantation was about 600. And over 1.5 years, we get impedance for 3000 ohm. Basing mode for this patient is VVI at heart rate 40 beats per minute, basing threshold 2 volt, at pulse width 0.4, and the sensed R wave is 6 millivolt. Do I need any change for this device? Actually not. This is a clinical picture of electrode myocardial interface. It results from a chronic inflammatory process, calcium mineralization of the tip of the electrode, and so I only need to follow up as long as I have good sensing and good basing. This is the impedance trend for many other cases. This is the normal trend. Here we can see abrupt drop in the impedance and then go back to the normal value. This indicates insulation breach. This is a connection disorder. We can see high impedance intermittent, then returning to normal, later on abrupt increase in the impedance, and same for lead fracture. And this is the electrode myocardial interface. And in general, if I have normal impedance with rapid oversensing, it may be lead fracture, insulation break, or physiological, non-physiological oversensing. High impedance with rapid oversensing, I may have lead fracture or connection problem. High impedance with normal, no documented oversensed episodes, it indicates lead fracture, normal functioning lead or connection problem. Low impedance with normal or high sensing episodes, it indicates insulation failure. Second thing, I will check the battery. The normal voltage of battery at implantation, normally about 3.1 volt. And last time for full charge. Both data will tell me about the elective replacement indicator. It collects battery impedance if above 3000 ohm, full charge time if above 15 seconds for most of manufacturers, and the volt of the battery if below 2.5. As long as I am in the elective replacement interval, I still have about 3 to 6 months to change the battery. Once I entered into end of life, I only have weeks to 1 month. And during this time, the shock therapy will be withheld. Second, I will check the episodes. I want to answer these questions. Was the therapy delivered to true tachycardia or no? If the tachycardia was at VTVF or was SVT with aberrancy or with one-to-one conduction. On the other hand, if no tachycardia was documented, was that oversensing due intracardiac or extracardiac sources like oversensing of the T wave, B wave, double counting of the R wave, extracardiac like electromagnetic interference, lead problems, and device problems. During the assessment of the episode, I want to use all the clues. Use the atrial and ventricular electrogram, check the onset, what drives what, the termination, response to anti-tachycardia basing. I want to check the ECG morphology, response to maneuver that I can do using RV basing. And to know what I will look for. This is the single chamber ICD. If it has proximal coils, we will get leadless ECG, like lead 1 ECG in surface ECG. Far field shock, it records from the shock lead to the can, near field or the sensing electrode from the tip to the ring, and finally the marker channel, which will mark the event once the sensing threshold is met. We will pass quickly through the cases. This is a case of B wave oversensing. Here, during sensed atrial beat, low voltage signals recorded on the tip. So only increasing the sensing threshold will solve the problem. Here we can see atrial flutter, which is misinterpreted as ventricular fibrillation. And due to dynamic sensitivity nature of the device, it's not recorded here. But later on, as the sensing threshold decreases, we can get the atrial devices. And most of B-wave oversensing resulted from using integrated bipolar lead, not the dedicated bipolar lead. Here, even for non-electrophysiologists, we can see this is an AF with rapid ventricular response, but the device treated it as VT. That's why, because we got B-wave undersensing. Here, the device didn't recognize that there is AF. It didn't shift it to mode switch or sense the atrial activity. So we have ventricular rate higher than the atrial rate. And according to the algorithm, if the ventricular rate higher than atrial rate, it will deliver the therapy according to the program. If both equal, we will go for morphology and sudden onset. If the atrial rate higher than the ventricular rate, we will go for morphology discrimination and interval stability, because most of time it will be AF with rapid ventricular response. We should check which atrial length, when shortened, the ventricular cycle length shortened, and when it lengthened, the ventricular activity conducted to the ventricle. Here we can see one-to-one relationship, and this is atrial tachycardia during stress, and then A. Now we have VAV with one-to-one conduction. The next step will be morphological discrimination, and this is what the device did. And on morphology, which Dr. Musallami mentioned, we didn't get much, so the device will treat it as ventricular tachycardia. We can get information from the anti-tachycardia basing. This is one-to-one VA conduction, and during V basing by ATB, it was terminated by VAV response with VA linking. The VA time here equal to the VA during tachycardia. So most probably this is an AVNRT case. The EGM morphology mentioned by Dr. Musallami. Although it's good algorithm, but still have problems. We may get aberrancy during tachycardia, post-shock distortion of the EGM, similar VT and SVT morphology, and we can appreciate it here. The device says this is a VT, but our eyes says, no, this is an SVT. And we will look for the morphology discrimination, we can get that it was clipped, and that's why there was mismatch and treated as VT. And this is during programming, we should increase the range in order to avoid clipping of the signals. Another trace, here we see in the leadless ECG, we can see B wave followed by QRS, B wave, QRS, B, premature atrial beat, then the tachycardia was initiated. But we got conduction aberrancy, and this mostly right bundle branch block morphology. So it was treated as VT, although we can see this as an SVT. Ventricular oversensing may be non-cyclic or cyclic. Non-cyclic may be extracardiac as myopotential or non-physiological like lead connector or electromagnetic interference. Cyclic include B wave oversensing, T wave oversensing, and lead failure as well. For electromagnetic interference, the typical one will be of high frequency, recorded at higher amplitude at the large antennas like shock leads, whereas a typical electromagnetic interference will be recorded only in one lead and will mimic myopotential. I will go fast through the listing slides. We may get myopotential, which is either diaphragmatic, more common, especially when using integrated bipolar lead, or pectoral. The pectoral myopotential will not affect the detection of tachycardia unless we have sinus tachycardia and then exceeded the VT discrimination time. Here we can see diaphragmatic potentials, which interpreted as VF. The T-wave oversensing may cause bradycardia due to post-pacing poses. We may have large R wave with normal-sized T-wave or small R wave with normal-sized T-wave, and in this situation, we have little options to solve. How to manage T-wave oversensing? Either increasing sensing threshold, dynamic sensitivity, filtering, changing from dedicated bipolar to integrated bipolar lead, or insertion of new sensing lead. This is how we can see when changing the detection of the bipolar lead from tip to ring to RV coil, from tip to RV coil. But this will increase B wave oversensing, R wave double counting, and diaphragmatic sensing. Current devices have T-wave discrimination algorithm. It depends on signal frequency. T-wave usually have low frequency and the pattern of the T-wave to exclude T-wave oversensing. Another item is conductor fracture and connection problem. It will be usually intermittent. It reaches the amplifier saturation, non-cyclic, variable amplitude, non-physiological signals. We can see the interval 140 milliseconds, and non-physiologic short interval non-physiologic signals. Lead integrity alarm in the current devices will notify us about the lead integrity. Pre-implant air in the header, it carry same morphology like VF, but initial acceleration and then de-acceleration, usually it's self-limiting, less than 24 hours. We will program the device to VOO mode if the patient is dependent on the pacing, and we will withhold therapy for about 24 hours. Finally, the undersensing of the ventricular fibrillation, it may be due to change in electrode myocardial interface, medications, algorithms within the device. And here we can see the patient was in sinus rhythm, induction of VF in VF, but the device can't see the VF episode. And 10 joule didn't terminate the tachycardia, still in VF, till he received external defibrillator. And on the first, regarding the R wave, mostly I will need to recheck the lead. To take home message, comprehensive data review is mandatory. Battery and lead integrity is critical for device function. We should check for appropriate versus inappropriate therapy. Check anti-tachycardia pacing efficiency. If not efficient for a series of cases, we need to change the programming. Patient symptoms should be take in mind. Documentation and follow-up plan, patient education are mandatory. Thank you.
Thank you, Dr. Mohammed. Thank you, Dr. Mohammed. I have one question for you. I guess the most important thing that we face, all of us are facing, is inappropriate shock, either for sinus tachycardia or atrial fibrillation. What do you do for the patient have recurrent atrial fibrillation and inappropriate shock? Do you change the parameter of the detection, or what do you want? What do you do?
As mentioned by Dr. Musallami, the stability of the RR, I will turn it on. It will solve most of cases. In manufacturer like Boston Rhythmic IQ, usually that will not depend on the stability. So I need to turn stability on.
Just turn stability on.
It will be enough.
Off. Okay.
I have a question from the chat of the audience online, who are 38 now. The question from Dr. Ahmad Ramadan, I think for you and Musalami, anyone can answer. Patient, he is speaking about a current patient under his service. A patient with hookah, he has paroxysmal atrial and wide complex tachycardia. He is receiving multiple shocks. What is your strategy? Or John?
The same question Dr. John asked. By the algorithm itself, we have more than V to A ratio is less than 1. So the second step is morphology
He
detection
is saying that he has underlying atrial fibrillation.
with conduction aberration.
And he is saying wide complex tachycardia, and he want to know are the shocks given to him appropriate or inappropriate?
Okay. This is
This is
answered by the
yeah.
organism, by the algorithm. If I have atrial activity more than the ventricular activity, second step will be two things: the morphology of the recorded on the morphology lead. The second set is the stability. If I have change in the morphology alone and the stability is off, it will be received as VT. The stability and the morphology. If morphology changed and the stability is stable with cycle length ranging 40 milliseconds, then it's appropriate therapy. Otherwise, it will be AF with conduction aberration.
John?
هو في الحالات اللي زي كده، هو فعلا الاستابيليتي انا شايفها هي ده المهم. لو ريجولار واي كومبلكس تاكيكارديا والجهاز واضح ان الار ار انترفال ثابته، لا انا هعتبر طبعا، انا هبقى الجهاز اعتبرها في تي وانا هبقى ماشي مع الجهاز. لكن لو الجهاز اعتبرها ان ده لو كان irregular واضحه، بالذات لو كان قبل الواي كومبلكس تاكيكارديا دي كانت مثلا الهارت ريت بتاع الانترنسك ما هو ايتا فيبريشن، بس الايفينوال كوندكشن زاد وبعد شويه قلب بالريجولار واي كومبلكس تاكيكارديا، ده فيفر ان ده قلب بابرن كوندكشن. فهو الاستابيليتي اعتقد هي الاساس في الموضوع.
أنا ممكن أضيف حاجة. I can add something about the clinical situation of the patient. Don't interpret only machine. You have to ask the patient, when you receive the shock, what were you doing? Running, fighting, and when you receive the shock, look at the electrogram immediately after the shock. Is it back? Sometimes they go back to sinus rhythm from the shock to the VT, which was not VT, it was atrial fibrillation. And then you ask him, did you have any syncope and did you recover? If you find such patient and receiving multiple shocks and he's still alive, then you have to think of inappropriate multiple shocks. This is my interpretation as when you put the data or the facts of the machine and the clinical situation of the patient.
There's also a summary in every episode. Summary, that means that he diagnosed SVT or VT, and according to this summary, the device will take the decision. So I should look to the summary. Maybe the summary take the decision about VT for wavelet, maybe from stability for VA distillation, and I should correlate between the summary of the device, why he delivers this therapy, to the clinical situation and the EGM. And from this summary, I will know that if he had appropriate or inappropriate. That is very important to this to see the summary. Okay, thank you.
Thank you, Dr. Mohammed. Thank you, all the speaker. We will move to the next session number 2, an interesting case in the EB.
Thank you very much.